Stigma in its many forms and manifestations creates so many barriers for people with substance use disorders and addiction to receive appropriate, timely, evidence-based, and patient-centered care. Despite this, there is a relatively limited amount of research, resources, and interventions and activities dedicated to dismantling the stigma of addiction in society and in the context of today's conversation in our healthcare system. That's why we're all here today. Although recognizing the detrimental impacts of stigma on access to high-quality addiction care and implementing addiction anti-stigma campaigns are important first steps, so much more work needs to be done to actually eliminate stigma towards people who use drugs and experience addiction. Maybe please have the second slide up on the screen, please. As a takeaway from our summit last year in partnership with the National Academy of Medicine, we were able to distill the key takeaways from the discussions during last year's summit into a formal proceedings document, and we identified 8 key focus areas for intentional and meaningful movement in reducing the stigma experienced by people who use drugs or who are experiencing addiction. These 8 focus areas are on the screen now. They are strategy, policy, research, representation, equity, funding, education, and inclusivity. We have used these concepts to help build out today's summit programming with intentional focus on shifting from concepts to actions and providing real-world, tangible examples and skills for our audience members to use in the building and implementation of their own stigma reduction efforts. Additionally, in January of this year, we convened a working group of national experts in healthcare-based stigma reduction to develop a collaborative theory of change and inform the development of a best practice guide for healthcare-specific stigma reduction initiatives and projects. We are delighted to be able to release this best practice guide upon conclusion of the summit today to all of our attendees. As I mentioned earlier, our steering committee has curated a fantastic group of experts and panelists for you today. But please know that we are aware the conversation does not end here. As you tune in for the remainder of the program, please be thinking about action. Consider what you might do differently as an individual moving forward, and just as importantly, think about how you might lead change in your organization and in your community. The Stigma of Addiction Summit has been built specifically to be action-oriented in this way. We'll talk more about this towards the end of our day today. And with that, you have heard enough of us talking, and we are very excited to hand over the mic to our amazing speaker lineup. One final reminder to please submit any audience questions via the Ask Your Question submission box below the video feed, and that information on how to claim CE for today's summit will be provided at the conclusion of our closing plenary session, and that we will be distributing the recordings of all sessions today to all registered attendees within weeks after the session today. Rachel, do you want to please take it away with our opening session?
Alana, thank you for that, and I'm happy to. As our speakers get moved into the room, I am going to start with some introductions. So first, we're really just excited about our opening session today, focusing on the importance of including advocates with lived experience into any and all stigma reduction initiatives. As a reminder to our audience members, and I know that Alana just said this, we do welcome your questions for an audience Q&A, which will close out the session. You can submit questions in the submission box below this video feed. Also, the session is approved for CE credit, and as we've mentioned, instructions for claiming continuing education credit will be provided at the conclusion of the summit this afternoon. With that, I'm going to start our panelist introductions. I'm extremely excited to have Dr. Samuel Roberts, PhD, who is an associate professor of history, socio-medical sciences, and African American and African diaspora studies at Columbia University. He also leads the research cluster historical study of race, inequality, and health, and co-directs the Lemon Center for American History. Dr. Roberts is a former director of Columbia University's Institute for Research in African American Studies. He writes, teaches, and lectures widely on African American social history, medical and public health history, harm reduction and drug policy, and criminal justice, policing, and social policy. Dr. Roberts is the author of the widely acclaimed Infectious Fear, Politics, Disease, and the Health Effects of Segregation, and is currently writing a book tentatively titled To Enter a Society Which Doesn't Want Them, Race, Recovery, and America's Misadventures in Drug Policy, a project covering the history of addiction treatment, harm reduction, and political inclusion from the 1950s to the 1990s. It is also my pleasure to introduce the moderator of today's session, Dr. Claire Clark. Dr. Clark writes and teaches about competing frameworks for understanding health behavior in context. She's the author of The Recovery Revolution, a book about the recent history of abstinence-based addiction treatment. Currently, she's working to social medicine for pre-medical students and a nascent exploration of the behavioral health field. Dr. Clark has received fellowships and awards from the APHA, the CDC, the McGovern Center for Humanities and Ethics, the National Endowment for the Humanities, and the National Institute of Health Office of History, among others. She earned dual graduate degrees from Emory University's Graduate Institute of Liberal Arts and Rollins School of Public Health. She's an associate professor with behavioral science at the University of Kentucky and is affiliated with the Department of History, Program for Bioethics, and Center for Health Equity Transformation. Claire, I will turn it over to you.
Thank you, Rachel. It is a pleasure to be here. We are tasked today with talking about people with including individuals with lived experience in policy development and in healthcare education. I thought we would start by talking about some successful and unsuccessful strategies for involving people with lived experience in stigma reduction efforts. And we can think historically, or we can think about in more contemporary terms. Dr. Roberts, do you have any thoughts about successful and unsuccessful strategies?
Strategies involving people with lived experience, I think historically, and Claire, you've written about this as well, there was a period until recently, I mean, we're still working on it. Things are not perfect today, but I mean, there was certainly a period where you simply did not trust people with lived experience to actually be at the helm or even really be participants in a lot of what we call today, recovery movements, and a lot of our social services. And I think that's, I'd be interested to hear your thoughts on this as well. But that's something, I mean, the earliest iterations that I've seen of people valuing the experience of people who have, lived this experience. You see it in some of the therapeutic communities beginning in the 50s and 60s. From what I can tell, it evolves into what today we call the peer system, maybe we should call it. And here in New York, the CASAC, which is a counseling accreditation. But there was certainly a period where we meaning society, did not value that experience. I mean, maybe have you seen something similar, Claire? And I know, Claire, I know you're the moderator of this, but it seems kind of silly that you would moderate one person speaking. So I'm thinking that we'll make this a conversation between the two of us until Dinah is able to join us, if that's okay with you.
I think that makes a lot of sense. I mean, when I've sort of written about this story, the way that I looked at the narrative of involving people with lived experience into, addiction treatment and policy efforts, that in a sense, it's that it's been one of co-optation, where people with lived experiences, voices, and stories can be sort of made to serve any political agenda almost. And that there is perhaps, that people from with lived experience are may rightly be wary of having their of the purposes to which their narratives might serve.
Right. I think that's probably, if not the most important thing. I mean, we might imagine there are things that are more important, but certainly who controls the narrative is certainly a centrally important aspect. I've been spending some time past few days reading transcripts of the Price-Daniel hearing, Senator Price-Daniel, 1955 to 56. This is digging deep in the crates. I'm sure our audience probably doesn't even care, but the point is that these were these hearings about narcotics laws, and they ended up producing some of our most stringent law enforcement measures before the war on drugs, before 1971 and before the 80s. And he parades, it's almost like literally a parade, all these people who are, in the parlance of the day, self-identified addicts. And you can tell they don't control their narrative. They have to answer yes or no, maybe a few details, but they do not control the narrative at all. And it's like the hearings are in 10 parts over a period of I think 12 months, maybe 15 months. I mean, it's all over the country. It's like major theater. There's probably, maybe dozens of people with lived experience who are interviewed, and they're never asked hey, what do you need? What do you want? Where did things, take a turn that you wish either you had done something differently or something had been done differently for you? Those are never the questions. So I think I agree with you. I think that narrative is really the important part. I would also say, kind of extending that, when you look at some of the organizations today, particularly some of the ones with which I work here in New York City, but they're all over the country. Some of our best harm reduction programs they're not just highlighting the narratives of people with lived experience, but people in leadership positions are people with lived experience, which I think is something that was fairly unimaginable until, I'd probably say, no, really not much later than the 90s. I mean, unimaginable meaning by the general populace. I'm not talking, there were people out there imagining it, don't get me wrong. I don't want anyone, emailing me and say, we were doing this in the late 80s, so what do you know? But I mean, in terms of the general policy environment, that was unimaginable. I mean, in a lot of ways, we're still trying to get government and official public health and academic, research institutions to recognize the importance of people who have a real deep knowledge and a study of it too, expert knowledge, not just experience, but they've given a lot of contemplation. I don't know. I don't know because I feel like I'm more into your field right now than I am in mine in terms of, your wonderful book, Recovery Revolution, lays a lot of this out, and, how we, some of that prehistory of where we are today. So,
I wish that Dinah were with us, because to the point of organizations that are doing this well, I would have loved to hear about her work with the Urban Survivors Union and the North Carolina Survivors Union. I've heard some representatives from those organizations give some fantastic presentations on what they call community-driven research, which is moving a sort of step beyond community-based participatory research, and asking questions about how can people with lived experience and people who use drugs be involved in research from its very inset, the study design, the very questions that are asked. I don't know if you could, if you might like to talk about some of the organizations you're involved with. I really would have loved to hear Dinah talk about what it's like being the voice at the table, and trying to make meaningful change.
Yeah, I would say, shameless plug from my good friends at On Point. I just joined their board a few months ago, and they are an overdose prevention site here in New York, a merger between long-running New York harm reduction educators, NYRE, shout out to my friends there, and also the Washington Heights Corner Project. And On Point's run by Sam Rivera, who is a remarkable ED and has been doing work in prison reentry and to diversion and all manner of things. I believe HIV activism as well. And so now he comes to On Point, breaking all of those skills. I think some 3 decades. I think he's been doing this work. Another one of my favorite organizations, I'm not on their board, but I do follow them where I can. I have some good friends there. Vocal New York is, they're, rightfully so famous for having, leadership of, people who are directly impacted with the lived experience. So that's just but 2, really, of the organizations out there. I think going back to what you were saying about community-driven research, as an academic, as you and I both are, I think we're acutely aware of that wall between, the university and everything, outside of the gates, right? It's someplace they call it town and gown relations. These institutions in which you and I work, quite often, and it's unfortunate, they cloister themselves from the communities that surround them. And some of the biggest and brightest, research institutions in this country, quite often they're situated in Black and brown communities. I'm not going to name any names, but I mean, you can just think of just some of the, there's a bunch of them out there. And breaking that down is still a bit of a challenge. From what I've seen, there's progress being made. You do have more and more organizations who are, demanding that they keep. Zena Age, who's an executive director of an organization down in Atlanta, gave a really interesting presentation about how she was able to, as you said, not just be her organization, that is, not just be a participant, but they actually directed the research agenda and retained all the data for their use later on for grant proposals, for doing their own studies. It was really important work, and I don't think I mean, I don't know every organization in the country. I mean, that's for sure. I'm a historian. I'm more versed with organizations in the past than the present, but I do know a certain number of them, and I hadn't heard of an organization doing that with such comprehension, with such thoroughness. I'm sure there are many others that are, but for those of you who are in organizations where you have that, wondering if that's possible, I would, really encourage you to reach out to people like Zena Age and others who have been able to do that. Because I think that is the next, that's one of the next frontiers for this work. And it's the importance isn't just about keeping your data. I mean, as you said earlier, Claire, it's about the research agenda too, right? Like you and I study in a lot of, as I read your work, that is, I think I'm doing an accurate read of, you and I both have an interest in the history of mental health theory, particularly as, this thing that we used to call addiction, right? It's got this long history of research. And you look at some of the research questions that they were asking and answering, in the 1930s, in the 1950s, in the 70s and the 80s. And it's clear they did not consult anybody with lived experience, right? Because they would have told them, like, that's not really how it works. But that didn't stop anybody in these research institutions at all. So I think it's really important because our knowledge itself suffers. This isn't about, bringing someone in for, because for the sake of doing that, which is a good reason in and of itself. But also we've been pursuing epistemologically, just, we've been barking up the wrong epistemological trees in a lot of ways. Maybe I'm putting.
While we get Dr. Roberts' video and audio back online, Claire, I think we should transition to maybe some audience questions and answers. We do have some in the chat that we can review. And then once we do get Dr. Roberts back with us, we can include him in that question and answer session as well. Oh, there he is. Welcome back, Dr. Roberts.
Thanks. That has never happened to me before. So I don't know what happened. I apologize.
No problem. The joys of Zoom and virtual conferences, not a problem whatsoever. I was just suggesting that we transition to our kind of question and answer portion of the session. We do have some audience questions that we can go through, and then of course continue with some final remarks before we close in about 10 minutes. Does that work for everybody?
assuming my Zoom allows me to remain, yes, that absolutely that works. I apologize again to everybody in the audience. I don't know what happened.
No problem. Absolutely no problem whatsoever. Let's see. I think we touched on it a little bit earlier at the beginning of the session, but I would love to hear some specific examples of what it looks like to have a true and meaningful integration of people with lived experiences involved in stigma reduction efforts or stigma reduction campaigns or other types of initiatives, rather than just tokenism. I would love to hear some maybe a little bit more specific examples. It is unfortunate that we don't have Dinah here to speak to some of that as well, but I'm sure that you both have insight.
Yeah, I think the issue, if I could, I'll go ahead and just, get us started. The issue of tokenism versus active participation from the very beginning is an important one. I think for some of the reasons that we were exploring during the Q&A, or not the Q&A, during our discussion earlier, that it's really important that we have people who know what they're doing actually inform us, meaning I'm speaking as a researcher, for example, but the us could be, policymakers or, somebody who's does not have that experience, for example. People who actually can, from the very beginning, tell people, how things should be going, or where things actually, or the research questions or the policy questions actually are misdirected or misguided. I think that's immensely important, because when you look at, just for example, one small example, the war on drugs, right? Which we now recognize. I don't think there's that many people out there who would disagree that it's been a failure. The difference of opinion might be between a failure and an unmitigated disastrous failure. But everyone, I think, would say it's a failure. And a lot of that, I think, is because is a lot of things. But I mean, one of them is that, we completely stigmatized and, demonized the object, people who we, ended up just locking away or pursued so relentlessly. We, meaning society. I had nothing to do with it. I was a child when all that started. So I think it's of immense importance. I think Dinah might agree. I've seen Dinah speak a bunch of times, so I'm not going to speak for her, but I would like to think that she would agree were she here to join us today.
I think it has to, I think it has to do with breaking down these divisions, and a lot of them are really rooted in historical injustice of notions that there are the researchers, there are or the decision makers, and then the people with lived experience, and that these are two different groups of people. There are a lot of folks, especially in harm reduction communities, that would say we're all people with lived experience. We all are people who use substances. And so this, the notion that there aren't already people with lived experiences that are leading research efforts, or that could be leading research efforts, I think is one that we're going to see hopefully evolve over the coming decades, because it's not like there are the idea that there are the addicts or the people in recovery and then everybody else. That's a very 20th century kind of notion that I think advocates like the people interested in this summit would be interested in overcoming.
Right. Now, Claire, I have a question for you. Is there, and I've heard that statement as well, that everyone has lived experience, and I agree with that. But then also, I have a bit of a concern about the kind of programmatic and political implications, right? Because couldn't it just be a very facile reason for somebody to say, "Oh, I've got lived experience. I should be the executive director"? But I mean, when we talk about lived experience, we mean in a more specific way. If we're having a discussion about stigma and the war on drugs and structural racism, for example, that's a specific kind of intersection right there. It's specific, but unfortunately, a lot of people are standing at that intersection. But we're really meaning specifically when they say lived experience, right? I mean, the lived experience of somebody who is, a middle class or wealthy white socialite who has their, pill prescriptions and the doctor just knows that they're using too many, but whatever, and they're able to use safely in their own homes is different from a lived experience of somebody who, I live here in Harlem, where like drug policy has been a problem here and a bunch of other Black communities for decades, right? I mean, there is a difference. Not when we say everyone has lived experience, I think we want to make sure we don't flatten it for everybody.
Oh, I think I would agree wholeheartedly, absolutely. And that differences in lived experience are important, but that we would want to see people with the kind of lived experience you're describing in leadership roles and agenda setting for things like like research and policy.
Yeah. Alana, were you going to give us another question or?
Yes. So there was a question, an audience question about the new SAMHSA Office on Recovery, and what your opinions are on how that could or could not impact stigma and stigma reduction, and how that could potentially lead to increased levels of trust between policymakers and healthcare providers, levels of trust that they have towards individuals with lived experience or individuals who do use drugs.
You said I think I heard what you said, the new what from SAMHSA?
SAMHSA has an Office of Recovery that they recently opened.
Oh, right, yeah. This is where I think it would have been really great to have Dinah here, because this is something that I think to which she's been paying some attention.
Correct.
Claire, do you want to start off on that one?
I don't know enough about it. It sounds promising, but I don't know enough about the details to be able to comment intelligently on it.
I would probably say the same. From what I've heard from people who have been paying closer attention, that there is some promise there. Of course, definitions of recovery vary. So that's the thing too. I mean, as Claire has shown us in her work, for the longest time, we equated recovery, or what we used to call rehabilitation, with abstinence. And, I would say the more critical and innovative people in the field have embraced, pathways to recovery, not non-abstinent recovery. There's a whole, the thousand flowers bloom in that regard. So if the federal government's behind, puts their weight behind only like one definition of recovery, that may not be as great. But aside from that, that's just really a question to be asked. I don't really have an answer necessarily to your question.
Excellent. We have about 4 minutes left, so I would love to take this time to give both of you an opportunity to share some final thoughts. What should our audience members take away from this session today as they go through the rest of our summit programming, and then as they kind of re-enter their day-to-day after that? Dr. Clark, can we start with you?
Sure. I think, the takeaway here is that the voices of people with lived experience you need to be included in decision making, and not just as sort of a promotional campaign or a rubber stamp sort of after the fact, after decisions are already made about, say, what research questions to ask or what kinds of policies to endorse. And and that we're desperately missing Dinah's contribution to this conversation. It would have been a much richer conversation if she had been here.
Yeah, maybe that's one of the takeaways. Look up Dinah Ortiz's videos if any of her speeches and talks have been recorded. I would say for me, we didn't really talk about the political dimension of stigma and the economic one, but I think it's important. I think the takeaway for our audience, I would encourage them to always pay attention to that. So our drug policy, meaning, the war on drugs, criminalization, we know it was never about the drugs, right? Like we never had any reason to believe that, crack cocaine was this demon substance, that crack babies were, being born all over the place. All that stuff was just nonsense. But it had a political and economic function. We disenfranchised politically, like literally with the vote, but also economically disenfranchised millions of people. And, it had an effect in the late 20th and into the 21st century on the texture of our politics. When a lot of people can't vote, they have no say in how they're governed. And when you think in so many elections where districts were decided with, 1%, and then you think of the number of people who might have been disqualified from voting because of a criminal record, served their time, done, debt to society paid and all that, but still aren't allowed to vote. Historically, that has changed the very texture of our politics. When you think of how like the 2000 election hinged on Florida, right? Like a few dozen ballots, but Florida had disenfranchised hundreds of thousands of people. So I think that's the stigma has a political and economic function that I think is a major takeaway that I would encourage our audience to keep in mind as well, because it's all of the same ball of wax, I guess. Okay, that metaphor completely fell apart towards the end, but I think you get my point.
Excellent. And thank you so much, Dr. Roberts and Dr. Clark, for the thoughts and commentary this afternoon. We're very appreciative of your time. I do want to once again recognize that our third panelist, Dinah Ortiz, was not available to attend today, and that executing this panel without, excuse me, the voice of a person with lived experience is suboptimal and doesn't provide the impact that we had intended throughout our planning process. And we appreciate our audience patience with that and some of our technical issues today. That does conclude our opening session on addiction, stigma, and advocates with lived experience. We are going to move into a 10-minute break before our first round of breakout sessions. Those sessions will begin at 1 p.m. Eastern Time, about from now. Breakout session 1, harm reduction and intersectional stigma, will be occurring in this tab within the video stream. Breakout session number 2, stigma in the healthcare system, will be occurring in breakout session in tab B, and our third breakout session will be occurring in tab C. One last reminder, for instructions for claiming continuing education credit will be provided at the conclusion of the summit this afternoon. It has been a pleasure to host you for this opening session. Please enjoy the rest of the summit programming today if your schedule does allow. Thank you.